Ladies and gentlemen, please welcome Foreign Policy Executive Vice President Allison Carlson to the stage.
Hello, everyone. Good morning, good afternoon, good evening for those who are joining us online from around the world. We're thrilled to have you here today. We're just coming off an incredibly powerful and impactful discussion this morning on climate and health equity. And thank you for staying for our health forum. We have an incredible lineup of programming today. We expect a few more people to come in the room as well. There's a lot of great networking and connecting that's going on. Can you hear me all right? Kind of. Let's see if I can connect this. Great. Well, thank you again for joining us today. You know, as the world emerges from COVID-19 and works to strengthen pandemic preparedness, we're addressing new threats, environmental factors, and inequities, many of which we touched on this morning. And these are posing significant challenges to governments, industry, practitioners worldwide. Today at our Health Forum, this is an opportunity to take a critical look at these issues and also the potential solutions. We'll be joined today by leaders from government, industry, civil society, and practitioners. Those are doing the work on the ground. You know, we're here today at the UN General Assembly where we're gathering amid the high-level meetings on universal health coverage, pandemic preparedness and response in the fight against TB. This is an opportune moment to learn and to mobilize. And this is a venue to really discuss where we're making strides, where we're failing and falling behind, and to be really honest about what we can do and what we need to do for action and impact. So a few questions that we'll be addressing today. How can we unlock and mobilize resources that will ensure innovation in healthcare, that will be efficient, impactful, and not just for the privileged few, but particularly for those in low and middle income countries around the world? How can we make sure that healthcare is a right and accessible to all? And what are the partnerships that are needed to do that? It's really important that in addition to participating in this discussion today, you can continue to connect with each other. I'm glad we have the opportunity to do that outside, but this is a real opportunity to forge those relationships and those partnerships that are really going to make a difference going forward. So as we gather today, I would really invite all of you to engage in the discussion. If you're here in the room and want to ask a question, please do so. We want this to be interactive, engaging. There's a QR code on your seat, and you can access the agenda, and you can submit your questions there, and they'll be monitored by my colleague, Claire. And if you're online, you can see on our platform where there's a button where you can submit your questions as well. Please do so. We really want to hear from you. And more than anything, we want to deepen our understanding, challenge conventional wisdom, and make sure that what we're doing today is actually accelerating action that will drive impact. I'd like to thank our partners, Cigna, EssilorLuxottica, and Viatris. Thank you so much. This event would not be happening without you, so appreciate the partnership. And again, invite all of you to ask questions and engage with us today. The first conversation that we're having, I'm very excited about to, frame the conversation, set the landscape about what we need to do to mobilize finance. And not just mobilize finance, but how can we make sure that it's driving impact? How do we measure it? How do we track it? How do we ensure that what we're doing is actually having an impact at a local level, but also is able to do so at scale? So for that conversation, I am very pleased to introduce Dr. Neal Buddy Shah, the CEO, the Clinton Health Access Initiative, and Professor Padmasree Gill Simpath, the ICEO of the African Pharmaceutical Technology Foundation. Thank you for joining us today. Thank you again. So I'd like to start off to set the stage and really frame the conversation and the conversations that will be held later on today as well as part of this forum. So, Buddy, I'd like to turn to you first. You know, you are working on the ground in countries around the world and mobilizing finance that will very much drive impact. And so when you're thinking about the environment that we're presently in, one that is resource constrained and complex challenges that are, you know, battling for resources in some instances, and in an environment where there's increasing debt, particularly in low and middle income countries around the world, what are some of the key trends that you're seeing in this space, and what are some of the ways that we can start addressing them?
Great, thanks, Allison. It's a pleasure to be here. You know, as we think about the UN high-level meetings on universal health coverage and tracking progress towards 2030, I think everyone's in agreement that we're not on track to hit those universal health coverage targets by 2030. But that having been said, if we look back at the last 20 years, I think there's been incredible progress in global health. We are coming at the back end of 20 years of huge amount of growth in global health spending. And that increase in spending has translated into, frankly, some of the biggest social impact wins that humanity, I think, has ever accomplished. So if you think about the creation of organizations like the Global Fund to Fight HIV, Malaria, and TB, the Gavi Alliance for Vaccines, President Bush's PEPFAR initiative, these are things that, in a really empirically defensible way, have saved the lives of tens of millions of people over the last 20 years. It's halved the rate of death from HIV, TB, and malaria in just 20 years, and that's absolutely incredible. And so there's a lot of success to build on from those 20 years of investment. I think the thing that concerns me is that we're entering into a period where there's a lot of risk for global health financing. And, you know, I know previous panelist Neil said that we shouldn't think about this as competition, but the reality is there is competition for resources with climate change, with the war in Europe, and also, I think, a certain degree of domestic retrenchment around, you know, our obligations to other countries in the world. And this is all layered on top of increasing debt burden for a number of countries in the world. And so the question is, what do we do about this? How do we maintain the gains of saving so many lives so cost effectively in light of those macro financing challenges? And I think there's three types of solutions. You know, the first is having more impact with the same amount of money. Over the last 20 years, we've really identified some of the most cost-effective ways to drive down maternal, neonatal deaths, vaccine-preventable deaths, and infectious diseases. And I think there's an opportunity for us to get more rigorous about investing in the most cost-effective ways to save lives and reduce the burden of disease by investing in proven solutions. I think the second way of having more impact with less money is using capital more creatively. I had a conversation with Noubar Afeyan, the co-founder of Moderna, yesterday, and he said it's amazing the types of discontinuous advances you can have when public financing is married with private sector ingenuity. And by giving a signal to private sector pharma innovators around, if you're able to develop breakthrough drugs that disproportionately affect low and middle income countries, the global community is going to guarantee you certain amounts of payments at certain price and certain volume, I think can go a long way towards making sure that innovation and R&D in the biomedical space is not just targeted at high-income countries, but at the health issues of low and middle-income countries. So that's on having more impact with the same amount of money. I think secondly is reforming some of the financing globally. I think the debt burden, 3 billion people around the world live in countries where paying the interest on debt is more than what they spend on health or education. And I think there's opportunities to reform multilaterals and the debt burden. And then the third is we have to crowd in more money. In the mobilization of climate resources, only 0.5% of funding is going towards health. And I think that even not as a health partisan, that's just a dramatic underinvestment since climate change ultimately manifests in negative health outcomes. And so how do we make sure that as the global community mobilizes a lot more money towards climate change, that there's the adequate amount going towards the health effects of climate change? So I think there's a lot of very practical things we can do in order to continue to build on the momentum of the last 20 years in saving lives, frankly, with extremely high value for money.
Yeah, thank you for that. And you make such an incredible point about the mobilization of resources, but making sure that it goes as far as it can and that's being utilized efficiently and driving that impact. And so I'd like Padmasree to turn to you, and you're now leading the newly formed African Pharmaceutical Technology Foundation. And, hearing what Buddy just said and thinking about your role, how would you characterize the landscape that you're seeing in Africa as it relates to the mobilization and deployment of financing that can have real impact? How are you making sure that you'll allocate those resources effectively?
Thank you, Alison. And I think in Africa, we're seeing a couple of really pressing challenges in healthcare. We have a rising burden of non-communicable diseases. We've got to deal with threats of pandemics. We've got epidemics surging here and there. And we also have to strengthen, actually, healthcare infrastructure, which has suffered, actually, under COVID-19. Africa has an enormous potential right now to participate and to have a voice in its own health care financing and building its own healthcare infrastructure. A first trend that I think is really important is that we've got a whole set of African institutions now which have emerged and are being strengthened at the African Union level. There's very strong investment by African member states and by the African Union in trying to change the historical way we look at healthcare infrastructure in Africa. So we've got not only the Africa CDC, of course, which plays a key role, and we've got actually the African Medicines Agency, which has been created. We've got the African Continental Free Trade Secretariat, which is trying to mobilize the region into a single sort of like trading region. And we've got agencies such as ours, the African Pharmaceutical Technology Foundation, which has been created specifically to reinforce the capacity of African actors in both the public and the private space to invest into critical healthcare infrastructure components in the region. As the African Development Bank, the regional development bank in the region, we are very heavily invested also in supporting these institutions. So we've got a new pharmaceutical sector strategy at the African Development Bank, which has actually put aside a $3 billion US investment into building Africa's pharmaceutical sector. We've also got the bank's healthcare infrastructure strategy, which tries to boost and crowd in financing within the African region, because we need about $26 billion in annual investment over the next decade to build Africa's healthcare infrastructure. And we're going to work very closely with all African governments and African institutions in making that happen. I do want to say one thing, though. A large part of our healthcare financing and healthcare investments in Africa go in sourcing stuff for the healthcare systems that we can produce locally, and if we would produce locally, we would and create the supply chains for it, we would probably have more timely allocation of those healthcare inputs, whether they are vaccines, whether they're drugs, whether they're personal protection equipment, other kinds of diagnostic equipment that we require in the healthcare infrastructure. And we can also increase actually our participation in providing those healthcare services within Africa. And I think that for us at the foundation and also the African Development Bank, strengthening that capacity in the region to do that for ourselves is a very, very big priority. And in that process, we want to reduce two kinds of risks that are very, very important risks in the region. One is a transactional risk, so a lot of the transactions that occur in the healthcare space, they are actually foreign exchange transactions where, African countries and African firms have to deal with currency fluctuations, right? And that actually affects the amount of money that's invested into healthcare financing and the ways in which we're able to leverage that actually to achieve maximum healthcare impact. So we're working very closely with countries to reduce that transactional risk. The second thing is the translational risk, you see. So when African firms invest into certain products and into producing, we need to make sure that they have the right kind of support structures. They have the markets that are needed, and we are aware and clearly supportive of procurement of those products into African healthcare systems. And those systems are well set up. And that's something that we're also working very closely in the foundation. A final thing that I want to say is that we've had, and I think Buddy's made this point, we've made a lot of progress in the global healthcare financing space. But what we need to do, and why we're lagging behind, is increasing the African voice in the healthcare space. And I think that this is something that we are really working towards in the region. We want greater participation of African institutions in mobilizing healthcare financing, in setting those healthcare financing priorities and in implementing them.
It's such a good point, and I'd love to pick up on that because you're both talking about the mobilization of finance by different entities, different groups. There are resources out there and capital is being mobilized. But how can we ensure greater alignment and harmonization among those activities so that they're streamlined, they're not redundant, there's greater efficiency and coordination? And just, Padmasree, as you're mentioning, there's a local voice and, those agendas are really being driven by those locally and local governments. So, Buddy, I'd like to turn to you. What is your perspective on that and what can be done to better harmonize and coordinate that activity?
Yeah, I think it's a great point, Padmasree. At CHAI, we work in 36 countries around the world, and we often think of ourselves as the plumbers of the public health system. So we're behind the scenes trying to find what's clogged up where and do the unsexy work of unblocking it. And when we speak, and when I speak with ministers of health all over the world, one of the things that comes up repeatedly is that it is very challenging to have a ministry-led, one plan, one budget, one execution model, given the number of voices of different donors with their own priorities, which are well-intentioned priorities, but often only partially overlapping with a cohesive, unified, ministry-led plan. Now, there's definitely been countries like Rwanda and others that have done an exceptional job of executing one ministry-led plan, one budget, and then you can either put money into that or not, and they're willing to reject money that's not aligned with the government-led plan. But there's a lot of work to be done on advancing that. And I think there's two different axes at which to do that. One is at the global level. There are these amazing global funding institutions like Global Fund, Gavi, and others that I think have the intention of thinking more about how do we align our spending globally, have the intention of making sure that it's harmonized at the global level, but then also in country at the national capital level, there has to be real intentionality and resources behind making sure all of the different funding streams, whether it's domestic tax revenue, global multilateral debt financing, or grant financing from these big multilaterals, feed into a single plan. And I think if we don't do that, it's going to continue to burden ministries of health. And so I think that's the key thing, to put ministries in the driver's seat in developing the plans and having all of the money that comes in be harmonized against ministry-led plans.
So we're about out of time, but I'd like to ask one last question to you both on that point. We're here this week where there are a number of funding agencies, a number of practitioners, ministers of health. What would be wins this week? What are some practical next steps that can come out of this opportunity to convene to really drive that action going forward? Padmasree, over to you.
I think a very important win would be that in these meetings that we sort of give a front and center seat to African institutions and African representatives actually to shape the agenda. For me, that would be very important. I mean, the African Union has now joined the G20, but I think that we need a stronger voice in shaping the regional response. We also need, I think that, in agencies like Gavi, GFATM, and so on, I think it's important to start thinking around, how do we work much more closely with Africa as a region, and how do we actually shape the responses that we have had for HIV/AIDS, for vaccine access, and so on, the successes. But start thinking around, how do we do that, taking into account the changing trends in Africa itself. And not only that it's a large market, but that market is a very big lever, actually, in terms of creating domestic capacity, in making sure that the region is actually ready and fit in the coming decades, actually, to respond to its own healthcare challenges. This is something that I'd really like to see.
And Buddy, what about you?
Completely second Padmashree's point, and would extend it to other countries, low and middle income countries, Southeast Asia, South Asia, and Central America. Two other things I'd quickly add. One is climate change ultimately manifests as health impacts, and it's unacceptable that between 0.5% and 2% of climate funding is going to health, and that needs to change. So I think that's one. And then secondly is there is so much to inspire us over the last 20 years of saving lives at high value for money that we need to continue that momentum. Now is not the time to sunset global financing for global health, but instead to learn from that as one of the greatest accomplishments of humankind and double down for the next 20 years to close this gap where, by the luck of birth, if you're born in a low-income country, you're going to live 20 years less than someone who happens to be lucky enough to be born in a high-income country. And there's a very clear pathway towards erasing that gap as long as the global community stays focused on it.
Very well put. Thank you both. Thank you for your time today. Best wishes with your work going forward. Dr. Neil Buddy Shah and Professor Padmashree Gill-Sampath, thank you for joining us today.
Thank you, Alison. Thank you.
Now for our next conversation, I would like to invite to the stage Katie Dane, CEO of the NCD Alliance, Luchika Ditu, Executive Director of the Stop TB Partnership, and Erica Satterwhite, Head of Global Policy for Viatris. This is for a conversation on mobilizing for universal health access to medicines. Thank you for joining us. And welcome. So I'd like to dive a little bit deeper into the issue relating to access to medicines, flowing from the conversation that we were just having specifically about financing. 8 billion people around the world don't have access to medicines presently. And that is from a range of issues, from supply, logistics, last mile delivery. And there are a number of complex challenges that need to be addressed in order to really get those medicines to where they need to go to drive that impact. So, Erica, I'd like to start with you. I know this is an issue that you've been working on for many years and is, central to your role. And so when you think about this issue, what are some of the major barriers that you're seeing right now as it relates to access to medicine?
Yeah, thanks so much for that. So access, as you said, is still something that we continue to strive for, I think, collectively. It's an agreed target that we all collectively are working towards as part of the SDGs, and we know we're not entirely on track. We know that there are people who still absolutely need access today. There are a lot of barriers. And I think part of the challenge that we face here is that there's no one size fits all. The needs of different people, the needs of different communities will be different. And I think one of the terrific parts is that today we have a panel focusing both on NCDs and infectious disease, the biggest infectious disease killer, tuberculosis. And I'm really thrilled that we have this opportunity to discuss, because People aren't impacted by just one or the other. People face health conditions across the span, with acute, with chronic, with infectious, with non-communicable, and how we look at the systems, how we look at our ability to sustainably enable that access. There are so many different challenges. I think there's a lot of learnings that we have when it comes to what worked, what didn't work in COVID.
Thank you. I hope that's better. Wonderful. Thank you so much. So I think part of when we're talking about the barriers to access to medicine, maybe starting with some of the learnings that we had from COVID and what can work differently as we move forward based on that experience is a good way to sum up where we see some of those key buckets of barriers. One of the things that became really clear was, as you said, around global supply chain. We need that interconnected global supply chain in order to enable us to reach people where they are with the medicines that they need when they need it. What also became very clear as a result of COVID, and the remaining barrier that we see, is around regulatory efficiency really matters, because there's a lot of back-end work that has to happen to make medicines available wherever they need to be. And there's a lot of improvements that we can make together in order to better enable that. We also need to really focus on what it means to have sustained availability. It doesn't matter if you have a medicine now, if you can't get it tomorrow, if you can't get it the next day, because it's no longer viable to have that. So there's a lot of sort of back end, speaking from a company that works on supplying medicines around the world. Last year, we supplied approximately 1 billion patients around the world with medicines across many different therapy areas: acute, chronic, infectious, non-communicable. It takes a lot. It takes a lot to even make that medicine available, and that doesn't even get into the next step. Once the medicine's available, how do we make it accessible? How do we make sure we're listening to the needs of people, of the needs of communities, building the right systems to enable that?
Thank you for that, and I agree. We're honored to have such diverse perspectives and complementary perspectives on this panel. And so, with respect to TB, Ruchika, I'd like to turn to you. And
I need this, or I need this? No, I need this. Okay.
That's a little bit better. That's a little bit better. Thank you. And understanding as well, as part of the high-level meetings, there's a big focus on TB right now. What are you seeing in terms of the landscape, and what needs to be done, what can be done this week to really address the urgency with TB, and how we can ensure, as Erica was mentioning, that we're able to get the medicines, the treatments to those people in need as efficiently as possible?
Thank you so much for the question, and really thank you for inviting me here. I come from the TB community, and I'm very happy to see that I can probably know just 4 or 5 faces in the room, which is great. I will keep saying that, because for tuberculosis this is great, because usually we speak to the same audiences and we cry among each other, with no outcome. Okay, if you tell you preach to the converted, it's like awesome, but nothing happens. So I'm really happy that I am here with all of you. First of all, because you're absolutely right, TB is a big drama. Very few people know TB is an airborne pandemic. Okay, you can eat very healthy, you can run every day, you can use condoms, you can avoid that and this and that, sleep under a bed net. You breathe. And the moment you breathe, you can breathe in as well Mycobacterium tuberculosis. Okay, very few people know about that, or acknowledge that, or understand that. And even worse, and you spoke about this week, very few people come to acknowledge. You see, we have today is the PPPR meeting, okay, about pandemic preparedness response. You see, COVID was an airborne pandemic. When COVID happened, everybody ran like crazy to the TB doctors, because we know to deal to the lungs. The hospitals and the laboratories have these infection control measures where they are. So they were the frontliners. Now, COVID passed, TB go back in the shadow, and in the PPPR declaration, the word TB didn't come at all, or it comes associated with an enumeration of other diseases. So you said what we do. I can speak about many things related to what you said, because you see, and linked to what you said before and what Erica said about access. The drama we have in TB is that people that are the most vulnerable are the ones that have obviously the least access to drugs, but also to diagnostics. We estimate 10 million people with TB every year. We are able to diagnose, according to WHO, 6 to 7 million. 3 million people are somewhere out there in this world. And not only that they suffer themselves, but because it's airborne, they infect others. So ensuring access to these people as easy as possible to diagnosis and treatment and care is essential for TB. But it's very difficult because those people are not like us. Even us, we are kind of delaying to go to the doctor. We are not very comfortable. So access is crucial. How do you make it easier for them? And we in Stop TB Partnership, we try to reimagining the way that we provide TB care by trying to bring diagnosis and treatments closer to the people. Using digital technology, artificial intelligence, any smart ideas and innovations to make all the barriers that are between a human being and the diagnosis and the treatment are being removed. So you said, and I will stop because you need to also stop me because I can go cuckoo. Because I found you all here, you know, I feel like lock the door and at least we have a group of people. At the end, they know, oh my God, if I cough, it might be TB. It starts with just that. But what can happen after that, you see a lot of people this week, even now we speak and we feel energized. Tomorrow we forget, we move to something else, is what happens when we leave. And the problem is that because I will tell something politically incorrect, but I am famous for being politically incorrect. You see, I heard that for the TB meeting that is Friday, there is no head of state or prime minister from a high-income country. Because it's not our problem. It's the problem of the poor. So what matters is what's happening afterwards. And even if there are the high burden countries' representatives themselves need to raise their voice and indeed come together and respect all these commitments that are made in this political declaration. And what we do from Stop TB, in addition to doing all this work on innovations and what we said, and we work close to Erica, and I hope we will work close with our friends from the NCDs, and I will make another point, is we work and empower the civil society and communities to be the ones to hold accountable their governments for what they promised. Everyone says, let's create an accountability system at the international level. Nobody will keep a president accountable better than their citizens if it's done properly, because they need the votes every 4 or 5 years, so they will better listen. The last thing I want to say, because I might not be able to speak again, is this. It's very nice you invited the three of us here, because the future, you see, I come here and say we need money for TB, right? HIV needs money, malaria, all the NCDs and so on. We need to be smart and invest in tools that can help the diseases across. Just to give you an example, we have digital portable X-ray now, and the result of the X-ray is read by the computer. It's fantastic. You have a portable thing, and it detects not just TB, but everything in the lungs, including cancer. So we can be smart, and we can benefit all of us on this. So I'll stop here before you.
Very well put. You raised so many very important issues, one of which was diagnostics. We'll be diving into that later today in greater depth. But on that note, I'd like to turn to you, Katie. It is clear that we need to have much greater focus on diagnosing, NCDs, TB, infectious disease earlier. And over the course of the pandemic, we saw how resources can be mobilized to that end. And so when you think about NCDs, what are some of the priorities in your mind and areas of focus that we all need to be thinking about and discussing to ensure that NCDs are top of mind and they can be diagnosed to then enable greater access to medicine?
Thanks very much. And it's always hard to get a word in when you're next to Luchika on these panels, I'd say. I mean, just to build on what Luchika was saying at the end there, I mean, I think first and foremost, we're all here for these 3 high-level meetings in quick succession: pandemics, TB, UHC. NCDs are obviously important to all of them, just as TB is. I think we're beginning to see the, real beginnings of the global health community working better together in an integrated, holistic fashion. I think if I look back to the 2019 UHC high-level meeting, things were very different. It was almost like we were all beginning to get to know each other. And now things are different. But I think, one of the main challenges, particularly from an NCD perspective, is essentially financing, which you were just talking about on the previous panel. Within the NCD space, we're still grappling with the fact that less than 1% of official development assistance for health goes to non-communicable diseases. What an absolute mismatch. I mean, NCDs are the #1 killer worldwide and are impacting low middle income countries the most, the hardest, people at a younger age. And the only way that we're really going to be resolving the financing issue is actually by making the pie that we already have go a bit further, right? In terms of actually integrating NCDs, TB, HIV/AIDS, women and children's health, and actually focusing on the primary healthcare level, where you can actually have, one-stop shops that are actually responding to people as a whole, rather than HIV over there, TB over there, cardiovascular disease and diabetes over there. So the financing piece is really difficult. I think in NCDs, in terms of the access challenges, within UHC particularly, in terms of what we need to see from a health system, is first and foremost investment in the primary healthcare level. Primary healthcare level is one of the most neglected parts of the system, and yet we know whether it comes to cardiovascular disease or diabetes, it's that community level that you can actually really reach people where they are. You can actually be detecting them early to avoid complications, hospitalization, advanced stages, which are so much more crippling, obviously to the people, but also to economies, because it's essentially kidney diseases resulting in dialysis and transplant, which is completely and utterly out of reach for so many people. And what is required in so many low middle income countries to actually achieve that is essentially a bit of a reorientation of the whole system to be more of a focus on chronic care. Because what we're seeing over, from an epidemiological perspective is huge advancements in things like HIV/AIDS. And so essentially they are now chronic conditions themselves. And so we need to be changing the system to actually be more proactive around early detection and treatment, around health promotion and prevention. How much have we actually heard this week about prevention? We know in NCDs that if you actually act early, if you focus on the common risk factors, smoking, unhealthy diets, physical activity, have a huge impact on actually reducing the burden. So, one of our messages within the UHC high-level meeting is you can't just focus on the health system. Governments have to focus on the prevention side as well. Sorry, I'll stop there.
No, not at all. Thank you, and incredible points. And just on that point on prevention, our team at FP Analytics did some research specifically to that end, really looking at the impact of investing early on NCD prevention and how that can have cascading impacts. And when we're talking about efficiency of resource utilization, efficiency of capital, and in a resource-constrained environment, investing upstream to address these issues, particularly in primary care, is incredibly important. And you also mentioned the opportunity this week and how, a few years ago, you were all just getting to know each other. It brings me to partnerships. And this also is an opportunity to get to know each other better, and also ways that the work that you're doing is complementary and can be so aligned. And so when we're thinking about that, Erica, I'd like to turn to you. Can you provide, some insight into how the private sector is playing a role, but also how the role of the private sector is really complementary to other organizations who are very keenly focused on access to medicine?
Yeah, thank you so much. I'm very passionate about partnerships. So this is terrific. And I'm passionate about it because it's not a nice to have. We can't get where we need to be unless we choose to work together and we choose to understand the different perspectives and the fact that it is the varied experiences and expertise that we need to have together in order to move us forward. It's not a nice to have. We need to partner because no single company, no single organization, no single country can do this alone. We cannot achieve access to medicines for 8 billion people working separately. And we can do so much more together, right? A company like Viatris, access is at the core of what we do. It's the center of our mission to empower people worldwide to live healthier at every stage of life. And it is everything. It is not just something that we say is an initiative, right? Access is not something separate. It is our business model. It is how we achieve our own impact. But we know that that is not something that we do alone. We are part of this ecosystem, and our core competencies in making medicine, in getting them to where they need to be, in developing medicine, in providing more scale to the entire endeavor, that can't happen in a vacuum. We need to work with partners. We need to work with civil society. We need to work with governments. We need to work with stakeholders throughout the ecosystem, because each has their core competency. And any single core competency cannot win the day. We need to work together in order to do that. And so I am very hopeful that we are at a time where that is realized, where that is recognized, where we know that the challenges that face us, where we stand today versus the Sustainable Development Goals, and knowing that there is so far to go in the 7 years ahead of us, I'm hoping that, again, we can learn from the experiences of COVID, in which there was some breaking down of those barriers and willingness to partner because of the urgency. That urgency is not gone just because COVID itself has become normal. That urgency remains. And so, if anything, I am more optimistic now that because of the urgency of that situation, we can carry that forward and realize there's so much more that we can gain by working together.
Absolutely. And I'd like to pose a question as a follow-up to you, but also for all of you to think about, is what's working? Can you provide an example of some of those partnerships that, you know, are breaking through, are having an impact, that may be unconventional or maybe innovative, but what's working and what can be looked to as a lesson learned and potentially either modeled or, you know, adapted for other environments? If each of you could think about that, I think to the extent that we can ground this also in concrete examples that others can take away and hopefully follow up with you on to also collaborate, I think that would be really helpful.
So I'm happy to start. And the example I'll give was already used on the panel before, but I think it's a great symbol, right, is the Global Fund to fight AIDS, TB, malaria, where private sector is actually on the board. There's actual a seat for private sector, in which, full disclosure, I sit in. So I know firsthand that having that space for private sector to sit at the table alongside civil society, alongside governments, alongside technical partners like Luchika, that is really powerful, to be able to have spaces in which we can all collaborate on an equal and respectful playing field aligned to the same goal. And so, not to say that the Global Fund should be something different or should be something more, not getting into any of that, right? But just saying that spirit of partnership entrenched in the foundation of an organization, I think, is so powerful to be able to move us forward from a common place of understanding.
And Luchika, from a technical perspective, what's working, you know, from where you sit, but also, you know, what isn't and what needs to change?
That's a very good question, but we need at least 120 minutes more. So no, but it's so much to say about the idea of the partnerships, and I also want to give to say 2-3 examples. I mean, like just enumeration, but in terms of what works, and we are not very good at that. Okay, let's be very honest, because the problem is, in a real partnership, every partners should do what is their own comparative advantage, right? You create a partnership and everyone brings at the table what they do the best. What we observe actually is a lot of overlap, and everybody is trying to make their own space and entering in the space of the other one. And you have people that are supposed to do data collection, that are doing community engagement, and you have people that are supposed to do guidelines, that are doing advocacy and financing, rather than saying financing is this. So you are a genuine partnership. Bring everything around the table with everybody that does the best that they know. And very important are two groups of partners there. And in the Stop TB, which are also, we have a seat at the board of the Global Fund, but we have our own board with a private sector constituency, and I see a few colleagues here with us. Is very important and very genuine, the relationship with a need for a very genuine relationship with the private sector, the industry, but as well private sector providers, as well as the civil society and communities. Traditionally, the civil society and communities, at least in us in TB, were to bring the TB survivors to tell their story and make the audience cry. Okay, that was the idea initially, right? You tick a box, do you have a civil society? Yes. Why? He tells the story. No, they are really the ones that should be at the center. And if properly empowered and properly, equipped with information and knowledge, they will drive the answer. If you want to penetrate at the ground level without civil society and communities, forget about it, okay? And they can come from different levels. So this should be genuine. but it's not, because there is a lot public sector with private sector. People run after me that I'm too close to private sector. I don't even have friends in private sector. But there is this idea, because I speak about the fact that we need to embrace the private sector, not only because of the money, but also of the know-how and everything that is brought at the table. But I want to say that it works. In Stop TB, we have two groups that provide funding to try innovative things. It's called TB Reach, which was initially funded by Canada. Now other donors are coming. And another one is Challenge Facility for Civil Society that is giving grants to grassroots organizations. And what these people do is amazing. We are funding early case finding in Pakistan for transgender people. You know, like people that otherwise will be terrified to go to get diagnosed, you know? Big vulnerability. We are, Pakistan as well is doing, we are funding a structure called Stop TB Partnership there. They are doing an engagement with the pharmacists in pharmacies in which they are part of the entire chain of diagnosis and follow-up of the treatment because they are very close around the corner. In Nigeria, for the indigenous population as well, you are able to go to their own communities by their own people and working together with the private sector providers, because in Nigeria, the first place to go, everybody is the doctor around the corner or the nurse around the corner that has a little private business. So there are models that work if you want to know in TB, but they can be actually applied to everything. And I know that we will speak with Kate for NCDs. We have a lot of these examples because every year we do 30, 40 type of funding in this way. Just to make you all smile, many years ago, we did a project in Lesotho and we spoke with the Minister of Health, what kind of engagement, and she said, everybody's constructing laboratories for us. Nobody is really interested how people reach the laboratories. So she said, can you buy us some donkeys? And we were at that time, we are a UN organization hosted by them, but we were in WHO at that time. So you can imagine the accountants in WHO when we bought 200 donkeys in Lesotho. And it happened and it worked. And afterwards, Global Fund continued. And now the donkeys are bought by the Lesotho government. So thank you.
That is not the example that I was expecting, but I asked for concrete examples, and you certainly gave us one, so thank you for that. And so, Katie, I'd like to turn to you to close. I mean, you are leading the NCD Alliance, and so when we're talking about partnerships, what are your examples that you can shed light on? What is working, and also what needs to happen to really move the dial and galvanize those who are here this week toward greater action?
I think building on Luchika, I think the first thing to say about public-private partnerships for NCDs is that, within public-private partnerships, you need to be focusing on people, right? And actually the needs of people. And so often I think PPPs are set up without even thinking about what actually the beneficiaries, the people that we're trying to reach actually most need. So I think that's the kind of the first point to make. The second one is, in so many countries that we support and that we work with, there are so many different initiatives happening basically on similar things. And very few of them are actually kind of making sure that the government priorities are actually the kind of North Star of what the partnerships are focused on. Every country in the world pretty much has a national NCD plan, and the partnerships that are happening in countries should actually be supporting that. And so often it's actually not happening. So really making sure that people are at the centre, government priorities are driving PPPs. And then the third thing I would say, which I think many PPPs over the years have kind of given short shrift on, is really focusing on monitoring and evaluation. At the end of the day, unless you're actually monitoring and evaluating the results that you're having in terms of whether it's NTD prevention or care, the impact that you're having, whether you need to course correct and change direction, whether, you're making progress faster than you can, for example, there's no point, So data collection, monitoring and evaluation is absolutely key, and I think sometimes forgotten in PPPs, essentially.
Absolutely. And when we're talking about a resource-constrained environment, ensuring that those interventions are data-driven, evidence-based to the extent that they can be. And when that data doesn't exist, are there technologies that can be leveraged? Is there, intel, knowledge that can be leveraged from other partners? And also, as you all very importantly put, those from the local communities, because at the end of the day, Katie, as you said, this is about people. So thank you for that. And thank you all for participating today and for the work you're doing. We appreciate it.
And now, please welcome Anurag Hans, Head of Mission of EssilorLuxottica and President of the One Sight EssilorLuxottica Foundation, Dr. Wanjiku Mutenge, Founder and Director of Training and Research at the Rwandan International Institute of Ophthalmology, and Dr. Magda Robialo, President and co-founder of the Institute for Global Health and Development. This conversation, Seeing the Bigger Picture, Universal Vision, and the SDGs, is moderated by Maggie Lake, veteran journalist and founder of Maggie Lake Media.
Loud voice. So, okay, there we go. It's great to see everyone. We are going to be talking about vision, and it was a fantastic last panel, and we're going to jump from donkeys to AI, if you can believe it. It's going to happen. So, but that just gives you an idea, I think, of the breadth of this topic. So, welcome to all of our panelists. Thank you so much for being here today. Dr. Robialo, if we could start with you. When we talk about the SDGs, and of course, that's the overarching theme of why we're here this week while the UN General Assembly is going on. When you talk about the SDG, health and well-being, vision isn't always the first topic that people jump to. Can you make the connection for us?
Well, you are right. Very often what people think about as diseases that need to be immediately addressed are infectious diseases because they are much more contagious, they cause high-level mortality, and the SDGs are driven by the major infectious diseases that afflict populations, particularly in poor, low, middle-income countries. So there is actually very low visibility about diseases that cause high burden, make people lose productivity. I can, for example, talk about trachoma, which is the leading infectious disease that causes vision impairments and blindness, which can cause up to $8 billion loss on economic productivity. Very few people actually know about this, and it's endemic in about 42 countries. You can have up to 90% of school-going children infected. So, unfortunately, the center stage is taken by HIV/AIDS, tuberculosis, and malaria, rightly so, because they have caused so much havoc. And these days we talk about COVID-19, we talk about Ebola. Infectious diseases that are spreading around tend to be more prominent in the global agenda. But we really need to bring closer home issues like blindness, visual impairments, because they cause a lot of suffering and push people into poverty because of inability to work, to go to school, to learn, and to do care for their daily lives. We need to make sure that the reinvigorated agenda after this UN General Assembly, the 3 health summits that are occupying a very good space in New York this week, when we think about universal health coverage, we don't just think about maternal mortality and infectious disease and child health. Those are important issues that we need to talk about, but we also need to think about the other diseases that are neglected. Everything cannot be a priority, but if we strengthen health systems, if we implement primary health care, we will be able to reach those people. These people are very often at the last mile where no one goes. They don't have access to health facilities, they don't have access to health care. And if we implement universal health coverage based on primary health care, we should be able to reach these children, these women. Trachoma affects 4 times more women than men. Very few people know about this. And women actually takes care of children, the household, and all that. That's a lot of loss for societies. And we hope that the more we talk about and bring this data to the fore for people to know, for people to speak about it, and we bring people of communities that are affected to lend their voice and ask for more support, we should be able to also address these issues while we tackle the others who are occupying our agenda right now, and rightfully so. I'm not saying let's not talk about or do something about HIV/AIDS, tuberculosis, and malaria, because we need to do trachoma and river blindness and etc. But we can address many other diseases at the same time if only we change the approaches that we have to healthcare and care for the needs of poor people in their communities.
Absolutely. And as it is the case with so many of this, it intersects several SDGs, right? You're talking about gender equity. We're talking about economic mobility and well-being. Dr. Muthenge, Dr. Obola mentioned COVID-19. What is the state of vision healthcare post-pandemic now? What's happening on the ground?
Okay. Thank you, Maggie. So I am an ophthalmologist and I work in both a public and a private hospital. But I'll start with some numbers. So there are about 40 million blind people in the world. People don't think about those huge numbers. If you add people who have visual impairment, which includes everybody wearing glasses in this room, then the numbers jumped to billions. And most of those people live in low and middle income countries. They are female and they're in rural areas. 9 out of 10 people who have visual impairment or blindness in the world don't need to have it. Their diseases could have been prevented or can be treated today. And the reason they remain like that is because of lack of the human resource to deal with those diseases or lack of supplies. Now, of course, COVID made all those things worse. There were breaks in the supply chain and access to services was just not available. Operation rooms were not working and people with conditions that need regular care really deteriorated and the numbers ballooned. However, COVID also brought us some hope because in the world of ophthalmology, we started investing a lot in telehealth and including solutions like artificial intelligence. Even in countries like Rwanda, we had to start thinking of those kind of solutions.
That's amazing, and I want to talk more about that. Anurag, Magda said everything can't be a priority. How is the private sector thinking about vision? Because I think that, and how it fits into SDG strategy, because it's true, at some point this becomes a resource game. So how are they and how should the private sector be approaching this?
Well, so I head One Sight EssilorLuxottica Foundation, which is the largest foundation focused on uncorrected refractive error, which is a subset of the vision issues that we're talking about. The fact is that 1 in every 3 people cannot see clearly, a condition that can be corrected through a simple eye exam and a pair of glasses. And we believe that being able to see clearly is a basic human right. Now, having said that, the solution to the problem of uncorrected poor vision is not a solution of counting the billions of people who need that service. The solution is about creating capacity because, specifically around refractive error, even if you distribute the billions of glasses that are needed, the fact is that in a year, prescriptions will change and people will need another billion. So the problem is not about counting how many of those billions have we corrected. The solution is how many of them have a permanent place to go to get an eye exam and to get an affordable pair. And that's the path that we are taking. For EssilorLuxottica, which is the largest player in the field of lenses and eyewear, this is just an extension of our day-to-day work. We change people's lives every time somebody puts on a pair of glasses, and we believe that should be true for everybody around the world, irrespective of where they live. So for us, it's not a stretch. It's not something that we have to do just so that we are able to check off the SDG box. It's a plain and simple extension of our mission to help everyone be able to see clearly.
If I'm listening to the three of you, it sounds like, and I love the point about capacity, because you're right, as somebody who's been moving up the food chain with my own my own prescription, it's true. It's something you have to do again and again. So that's a great point, as opposed to just handing out the glasses, because I think we've all encountered those programs. It sounds like you're all saying that this is solvable, though. Am I hearing you all correctly, that this is not we need to find a cure, it's that we need to increase people's access? Is that the case? Yes.
So I'll give you my point of view. I'm a huge optimist, and I believe that this is not going to be an issue that we will be sitting in this room talking about in 10 years' time. So there are many problems in the world which afflict billions. I can tell you that uncorrected poor vision, especially refractive error, which contributes to 90% of all vision issues, will not be an issue that we'll be discussing in 10 years' time. The reason for that is also linked to what Chiku was saying about the impact that the pandemic had. On the downside, we've seen that because of increased screen times, myopia rates have gone up. But the plus, the positive of the pandemic was that a lot of countries have had to move on, let's say, telehealth policies that they've been sitting on for a long time. And because of that, now telemedicine is going to become the standard way of delivering care for uncorrected refractive error in the rural parts of the world. In fact, I would like to say that the rural regions of the world are going to leapfrog and completely skip the stage of creating these physical access points with physical technicians who are based there, and would completely bypass that stage. And then we're only talking about scaling up the platforms of teleconsultation and telerefraction that are already there.
I think a lot of people are going to be surprised by that, because a lot of our experiences, and I don't know, you can nod in the audience if it's true, is that you go to get your prescription renewed, you go to get your eye checked again. I see you, Chiku, nodding your head vigorously. Are you seeing this happen on the ground with the work that you do, and what does that look like? You mentioned AI before.
Yeah. So like I said, one of our biggest problems in the world of eye care is trained personnel. And where I work, we have very, very few ophthalmologists. And unfortunately, the leading causes of blindness are, in my part of the world, it's cataract. In your part of the world, it's age-related macular degeneration. Those are diseases that need ophthalmologists. So our strategy is let ophthalmologists do what only they can do, and then find solutions for other tasks to be done by other people. And so in Rwanda, or in Africa, what we are doing is we are running a primary eye care program where we train nurses in the frontline health facilities on how to do a basic eye examination. So, nurses can do a lot of things. They can deliver babies, so checking an eye is not that complicated. So we teach them how to basically separate a normal eye from an abnormal eye, and then the abnormal eyes decide, what can I treat? What do I need to refer? What do I need to give first aid before I refer? And then we give them the skills to do all that. And in Rwanda, we've trained 2 to 4 nurses in every health center. And already what that does, it brings eye care within 5 kilometers of every household. On the other side, there are diseases where we need people to be found early and come for care to the ophthalmologist, and that's where technology comes in. So I'll talk about a disease like diabetic retinopathy, which is a complication of diabetes. We need to examine the retina to know that this person is at risk. We don't have enough people who can examine the retina. So what we've decided is that let's rely on technology. So in Rwanda, we want to put in cameras into diabetes clinics, take an image of the retina, upload that to artificial intelligence, and then you get a yes, you need to see a doctor, or no, you're fine for another year kind of report. And we've already tested this and we are implementing it already. So we are going to skip the reading center ophthalmology pathway that is what is followed elsewhere and probably just go directly to this if we can afford it.
That's amazing. And something I think when we talk about AI, we know it snakes into every conversation, but this is a really tangible example and probably something most of us were not aware of. Magda, you talked about that last mile. There are obviously these innovations, technologies moving quickly. How do we work on accessibility and what's needed in terms of that?
Thank you. I hope I didn't leave the impression that everything is a priority. I meant that we can't make everything a priority, so we need really to strategize. But if we have the right approach, we can tackle many more diseases than we are currently doing. What she has just described is the strategy that we need. We need primary health care. People need the care for the symptoms, the disease they have, as close to home as possible. Unfortunately, we have a major problem with human resources, health workers. We would have loved, many African countries would have loved to train their nurses to also do high check. But these nurses are overburdened, underpaid, they have poor working conditions, and it is difficult to add something else on top of what they are already doing. That's why it is important to invest in the healthcare workforce. It is important to find the fiscal space, the financing that is required so that countries can expand the healthcare workforce and provide the kind of services close to the rural areas, close to the last mile. Most visual impairments are preventable. I want to believe they are the experts. And if we do address social determinants of health, if we address access to quality water, if we address quality access to sanitation, better housing conditions, a lot of these diseases will just become things of the past, just like they have become a thing of the past in developed countries. So there are several SDGs within the 2030 agenda that will need to work together in order for us to achieve the outcomes that we expect, not just SDG 3. So apply primary healthcare strategies, bringing care closer to where people live, improving their living conditions, and then giving them the ability to also participate in decision-making about their home health, not bringing the technology, the innovation, and say, this is what you need, but listening to them and then making them be part of deciding what are the most important things for me today. Sometimes they don't even think of their health. Sometimes it's food. Sometimes it's education for the children. So this is where we really need to make sure that the intertwined dynamics between the 17 SDG goals work for the people. The public-private partnership is very important. There is no government in the world will be, particularly in low and middle income countries, will be able to solve this alone. There is no way we'll be able in 10 years to have high-tech access to care in most countries, because you have rural areas where there is no electricity, there is no water. There's no way you can actually apply telemedicine and all these. I don't want to call them fancy because they are very simple, but for people in those areas, it's actually fancy technology. We want to be there. We have to leapfrog. Africa and other low and middle income countries don't need to go through the painful steps of development. We can really jump steps, but of course it takes proper governance. It takes pro-equity governance. It takes leadership. It takes vision, not just vision to see, but vision of thinking into the future. And that's where sometimes we have problems with our leaders.
This is where the issue of awareness becomes so important, so that you can address this from a holistic point of view, right? Nothing is in a silo. And if you take that approach, you can often address many of these issues at the same time and pool resources for that. I think we have a question from the audience.
Sorry, I'll just project. So Lori Garrett here in New
Anurag, I think you're in a good position to answer that.
So I think the process of what I said, building capacity to do this over and over again, is almost like, if I had to draw a parallel, it's almost like erecting mobile towers or laying the cables for high-speed internet. Once you do that, then you can deliver affordable products to people who can afford. You can distribute for free for people who need philanthropic help. But it's important for you to have created that capacity. Distributing free glasses has its place in the world, but I don't think that will solve the need for more than 20% of the entire population that we're talking about. Now, just to link it to the point about AI, I think a lot of times the conversation gets lost between, is AI going to replace a human who's right now doing a job? But in these contexts that we're talking about, AI is actually going in and filling up a gap that was not occupied. So as we speak, our teams are, I'm giving you an example, our team is deploying an AI-powered chatbot, which is interacting with people living in rural areas in Indonesia, answering questions, basic questions about vision care, and then directing them to the nearest vision care point where they can get an eye check and a pair of glasses. Similarly, predictive models based on big data is drastically going to reduce the complexity of this entire chain and the time taken. And this is not something which promises to be in the future. This is something that is happening right now, not in the top urban centers of the world. This is something that is being deployed by us and many of our government partners in areas where right now there is no capacity. So, yeah, so again, to your question, it's about building capacity. Now, that capacity will look very different from the optical points that you see here in New York. It's going to be digital centers which are overseen by an optometrist or a refractionist sitting miles, thousands of miles away, but delivering the same standard of care closer to where the people are living. So.
And it's a matter of short term, and then it sounds like the medium to long term, building that capacity. Do people who can't see need those glasses now? Absolutely. Is there a place for that? Absolutely. But if you want to solve the problem for the future, then access. We're almost out of time, but Shiku, I'd like to have leave you with the last word. As somebody who's a practitioner on the ground, working hard to solve this, and I think we've heard about the importance of public partnerships. I mean, they're essential to all of the SDGs. What do you need? What would you like to see? What do we need to do? I mean, what do those public institutions, as well as the private sector, with the financing they bring, need to do to help move the needle on this?
I think, investment in training people, because, money can buy hospitals and drugs, but it can never buy the trained doctors and nurses that we need. As you said, I think there's a role in distributing free glasses, but I would rather see manufacturing plants opened in Africa. There's not a single spectacle manufacturing plant in Africa. Why is it the most complicated thing to manufacture? It's not. So I would like to see investment going that way rather than... That
shocked a lot of people, when you just said that.
Yeah, and our spectacle frame is a piece of plastic. The lens is a piece of plastic too. I'm sure we can be taught how to do that. So rather than spending so much energy distributing free, I wish that energy would go into creating at least a factory. Yeah. Thank you.
And Magda, same thought from you. What's needed, especially with your view on the larger healthcare system? I heard you talk about universal health care several times.
Universal health coverage is a topic that will be subject to leaders' conversation for a political declaration tomorrow. And we want to believe that within that frame, there is room for infectious diseases, non-communicable diseases, and high care meets both agendas. But most importantly is the issue of partnerships between to global north and global south, the public and the private with communities at the center. That only will be able to enable countries that are left or are staying behind to leapfrog, like I said before, and provide the care that people need. We are talking about local manufacturing of medicines, diagnostic vaccines. We are only thinking infectious diseases. And she just said something very important. Why can't we produce spectacles in Africa and other low-income countries? So we need to broaden our thinking. We need to think beyond infectious diseases and the things that we have currently in the box. And stages like this are very important. I'm really pleased to be part of this conversation where we are talking about something different, unusual for me to talk about. Even though in the world of infectious disease where I navigate, I know neglected tropical diseases cause visual impairment and blindness, but we need to do more of this. We need to bring these neglected areas of essential care to the fore so that those who think about broad issues, shape global policies, think better and include such important pieces of work into the agenda for everyone, because there are billions of people who will benefit from just improving the access to care. And if you train that we need to do, healthcare workers, they will also be able to take care of our high side, which is so important.
It is. And Anurag, very quickly, I think you should leave us with the sentiment that, again, this sounds like something, all of us are talking about these big issues, that there can be quick progress on this. This can make a difference almost immediately.
Yeah, I think as I started with, the issue of uncorrected poor vision is most likely to be the biggest success story in the field of public health care. And I'm very optimistic and very excited about the role that technology is playing in creating capacity to solve what is probably the biggest disability in the world. Sometimes it's easier to paint a new picture on a blank canvas than to correct something which already is existing. And I think we have that opportunity, and we already have the models which work. With new technology coming in, they're just getting better.
And that will be a generational change. Thank you all so much for shedding light on this.
But will not likely take a generation to solve.
Exactly. So I hope you all feel empowered and inspired by that. Thank you so much.
Thank you.
Thank you.
Thank you. Go off this way.
Please welcome to the stage Deputy Executive Director of the United Nations Program on HIV/AIDS and United Nations Assistant Secretary General Dr. Anjali Atraker for a conversation on eradicating AIDS by 2030 with FP's Executive Editor Amelia Lester.
Thank you so much for having me.
I'm excited to talk about what is, by all accounts, somewhat of a good news story, because we're here to talk about eradicating AIDS by 2030. And I wondered if you could start off by telling us a little bit about where we're seeing progress and where we are more generally in the fight against AIDS. It's been nearly 40 years now.
Well, first, thank you for having me. It's really an honor to be here today to talk about something that is actually a shiny, bright star. What we have seen in the 40 years is moving from death and despair to life and hope, to promise and possibility. That's what we've seen in the global HIV response, and it's been extraordinary. You know, and this is across the globe, we now have, of the 39 million, people that are living with HIV and AIDS, we have 30 million of those 39 million that are on life-saving treatment. That's an enormous testament. We still do not have a vaccine or a cure, but we have incredible progress that we're seeing. In fact, it's really interesting to be here during the UNGA week, where many of the Sustainable Development Goals are struggling. What we see in the HIV response is success. We see countries that have moved along this path and are making progress toward their Sustainable Development Goals, unlike all the other SDGs. And this is really a testament of the power of partnership.
Yeah, I'm excited to dig in a little bit on how we got here. And perhaps you could tell us a little bit about the role that legal and policy frameworks have had in making this amazing progress.
Absolutely. You know, I come from the United Nations, and what UNAIDS is a joint United Nations program on HIV and AIDS. It was created in 1996 to respond in a comprehensive way to a comprehensive problem. And so this is the only joint program that exists that includes 11 different UN agencies with different disciplines across finance, across human rights, across health, across women's issues, children's issues. And what has been important then and what is important now is that UNAIDS, together with governments across the world, have come together to develop a plan that holds all of us to account. We have 5-year targets that we come together always to say, where are we against these targets? How are we progressing forward? We have a declaration where we have that outlines the work that we do together, that signals the incredibly important characteristics of what it is that takes to end AIDS and what we need to do and what all governments and communities need to do to continue along the fight.
What's really striking to me here is how the world came together and then set itself accountability goals to check in on progress. I'm wondering what this fight against AIDS has taught us about combating future pandemics.
Well, it's interesting. You know, AIDS is a pandemic. We have 40 years of experience fighting one of the largest global threats, and we've learned a lot. We've learned a lot in those 40 years, what works, what doesn't work, how we need to come together in a multi-sectoral way. And so what we've learned about pandemics, and most recently through the COVID-19 pandemic, while we've been battling and fighting HIV, is that many of the lessons that we've learned from the HIV response are indeed applicable to other pandemics. Same for COVID-19, for Ebola, for H1N1, for MERS, for SARS. Many of these, and they're similar things. The power of, and what we learned in the HIV response and what we continue to learn is how important it is to have person-centered care, to have communities at the center of what our focus is, to work in a multi-sectoral way, bringing multiple disciplines together, bringing multiple ministries from governments together, bringing parliamentarians together with health officials, bringing finance together with gender and justice and what that looks like. And as you said, accountability metrics, that's something, using data and evidence, that's something that we have championed and treasured in the HIV response. And I think that's something that, you know, as we think about these broader frameworks, there's a lot that we can learn from the HIV response.
One issue I really want to get to here is PEPFAR. Global solidarity has obviously been key in the HIV response, but in some ways the United States has really led that fight, particularly with PEPFAR, or the President's Emergency Plan for AIDS Relief, started by the Bush administration in 2003, saved an estimated 25 million lives. It needs to be renewed by Congress this year, doesn't it? So you've helped lead it. Tell us why reauthorization is important and what's at stake in that renewal.
Thank you for that question. And it is indeed, you know, when we talk about the global HIV response, and when I talked about some of the incredible progress that the globe has made together, a really important reason a lot of that progress has happened is because of the American people, is because of the President's Emergency Plan for AIDS Relief. And what that is an enormous partnership and enormous amount of funding and political commitment and will that has come together with the launch in 2003 by President George W. Bush and the continued bipartisan, bicameral support across the subsequent administrations and Congresses to put their resources where the possibility and impact and the need really was. The U.S. government had, over the past 20 years, invested over $110 billion into the HIV response that has represented the U.S.'s contribution to the global HIV response. And it's been an extraordinary partnership between the U.S. government and partner governments and communities in over 55 countries. That very investment and that very partnership has resulted in 25 million lives saved. It's resulted in systems, local systems that have been strengthened, laboratory systems, surveillance systems, supply chain systems, health and community health workers that have been strengthened through the HIV response that both save lives, but also build local capacity so that countries can continue to respond to HIV, but also be prepared for other pandemics. So PEPFAR reauthorization and continuing that bipartisan support is essential. We have not yet finished the fight. Despite the progress that I described earlier in the HIV response, we still have 9 million people that are in need of treatment that do not have treatment, including mothers and babies and adolescent girls and young women and key populations where new infections are rising. We need PEPFAR to be continued, to be extended for another 5 years as the law continues, and funded so that we can continue to finish the fight and sustain those gains into the future well beyond 2030.
Well, that was an important call to action, I think, for Washington and for policymakers. And let's hope that the race to the finish line in 2030 continues apace. Thank you so much for being with us.
Thank you. Thank you so much for this time.
All right, well, I'm excited to introduce our next guest, is Arjan Tor, who is the CEO of Cigna Europe. He has held this position since January 2020. Thank you for joining us today. Arjan, we're meeting today to talk about universal health coverage and mental health. I thought it'd be helpful to just briefly contextualize what you do. You're responsible for the overall management, growth and profitability of Cigna's operations across Europe and the UK. And I wanted to hear a little bit today about mental health in a workplace context, because we're certainly hearing more and more about this as an important part of public health and healthcare generally. But I'm curious what you can share with us about how big this issue is in workplaces.
Sure. And first of all, thank you for having me and thank you for being part of this really important conversation. A lot of really important health-related topics have been covered earlier today, but we haven't really spent a lot of time talking about mental health. And at the risk of maybe sounding overly dramatic, I do think we're actually faced with another global pandemic, which is a mental health pandemic. It's a huge issue and it's an ever-increasing issue, unfortunately. So WHO recently indicated that on an annual basis, we're losing about 12 billion working days in productivity because of anxiety and depression. And that represents about $1 trillion in actual loss of productivity. So it's a huge issue. But of course, behind those big sort of macro numbers sits a lot of pain, a lot of emotion, a lot of individual issues that people are faced with that I think as a society, but also from an employer perspective, we need to make sure we address.
And are those numbers getting worse, do you think? What's the trend line?
They are. Cigna recently did another survey amongst workers around the world that indicated that 88% of all workers are suffering from symptoms of burnout. 88%, that's a really scary number, and it's never been that high. So we definitely see that go up year over year.
What are the causes of that, do you think?
Well, I think not all of it is workplace related. Let's be clear on that. We are going to be talking about the role that employers need to play here, but it's not all workplace related. At the same time, we do know and understand that things like the feeling of needing to be always on, needing to be always connected, the blurred lines between personal life and work life, which of course, because of COVID and the fact that everybody's been working from home, has been amplified. It's not a new issue, but COVID has definitely made it worse. I mean, those are some of the things that are definitely playing a role here, but we also see in our research, people are increasingly worried about the future. They're increasingly concerned about financial situation, which of course in a high inflationary environment, it's not really helping.
Right.
So it's all these concerns sort of, contributing to that overall increase in mental health related issues that we see.
So pandemics, inflation, cost of living, these are problems that employers alone can't fix.
That's right.
What can employers do to alleviate this suffering?
Yeah, and again, I do think employers have an important role to play. First and foremost, because that loss of productivity has a real impact on employers' ability to deliver on their overall objectives. Secondly, because we all spend a lot of time in the workplace, so it is important that a lot of these issues get addressed in the workplace as well. But then thirdly, and I think this is really important, something has fundamentally changed in the way employees are expecting their employer to step up and deliver comprehensive health and well-being support. So again, Cigna does a lot of research in that respect, and the most recent study that we did indicated that 40% of all employees expect their employer to play an active role in helping and supporting their overall health, but also their mental health. At the same time, the reality is only 24% of employers are actually offering that. So there's a significant gap there. And that's a risk to employers because we're also in a war on talent. There's a shortage of skilled staff in many parts of the world, in many industries. And if employers want to be able to win that war on talent and want to be able to attract and retain the best people, they're going to have to step up and they're going to have to do more. Now, you asked me the question, what can employers do? So I think it's a couple of really important things. First and foremost, help remove the stigma around mental health, because that is still a really important issue. And by setting the tone from the top, by talking about mental health in the workplace and acknowledging that it is an issue, I think that already makes a huge difference. Help people in terms of the access to mental health care. That's another really important thing. We work with a lot of employers who are putting in place comprehensive mental health programs, including digital mental health support, cognitive behavioral therapy programs, on-site medical screenings. So all of these things help to make it easier for people to get the help and to get the support that they need. So those are two very tangible things that I think employers can do.
Arjun, thank you so much. We're out of time, but I've learned a lot in this brief period with you. Thank you.
My pleasure. Thank you for having me.
Thanks. Okay, now I would like to introduce a panel on funding mental health and wellness. And on this panel, we have 4 panelist members. The first is Nathaniel Counts, who is the Senior Policy Advisor for Mental Health to the Commissioner of Health and Mental Hygiene for the City of New York. Dr. Stella George, who is Chief Medical Officer for International Health at Cigna Healthcare. Dr. Devorah Kestel, who is the Director of Mental Health and Substance Abuse at the World Health Organization, and Professor Miranda Wolpert, who is the Director of Mental Health at Wellcome Trust. Please welcome the panelists to the stage. Okay, thank you for being with me, everyone. I'm excited to get into this big topic, as we were just hearing about. It's one that's getting worse and that we need to focus on strategies to solve. I can't help but notice that this panel is coming at a really crucial time. Tomorrow, the United Nations High-Level Meeting on Universal Healthcare is happening. And yet 75% of countries have not fully integrated mental health into their health systems. So it's clearly something we need to talk about. This is despite the fact that many mental health conditions can be solved at a low cost. So I want to speak to the panel today about how the world can come together to broaden access to quality and affordable mental health care. And I especially want to dig in on that intersection of mental health and universal health care. Dr. Kestel, I wanted to start with you and draw on your 25 years of experience in implementing and advising governments on national policies related to mental health systems. Given a large percentage of countries have yet to fully integrate mental health into their health systems, what are the barriers to getting this up, and how might these be addressed by policy decisions in country?
Great, thank you. Thank you very much for this opportunity. For those who don't see, we have the time in front of us, and I wonder if I can use it all to answer to this question that is broad and very important. We you know, from the World Health Organization perspective, we do have countries committed to advance mental health, and this is part of an action plan that was endorsed by all member states. But what we see is that they really struggle in making that happen. The real integration of mental health in the mainstream of the health sector is what is lagging behind. And the barriers are many, and depending on the countries we are talking about. But in general, we know that only 2% of the health budget goes to mental health and public health budget, and that is, of course, very little money when you need to provide answer to the diversity of situations that are related to mental health needs. Furthermore, in many countries, around 60–70% of that 2% goes to old-fashioned psychiatric institutions, and there is nothing there for community care. So that's one clear barrier, financial issues. Another important barrier is information. The countries don't know exactly what is the situation. There is very limited information that is being collected on a regular basis by health practitioners, and that information collected may end up being in a notebook, never ending at the level of decision makers. So that's another important gap. As a consequence of all this, there is a treatment gap. People do not receive care when they need it. And we are talking about between 50 and 90% of people with mental health issues not getting access to care, quality care, etc. And a big component of this is stigma. Stigma is still very important. When you said in the introduction that the problem is growing, and I always, yes, it grows significantly as an immediate consequence of COVID-19, but it is also true that we are talking more, we are hearing more about that. So in some contexts, in some countries, stigma is going down, and so we see more of those situations. But that's not global. Stigma is still a very important component. So strategies to overcome all that are diverse depending on which one of the gaps we want to work or to deal with. Definitely the integration of mental health at primary care level, at the level of specialized care for other conditions, comorbidities, the issue of considering mental health when talking about a life course approach from children to maternal health to different issues according to the age. So not only when it's about a disease, but also when it's about life. Yeah. And then those are some of the strategies that should help, and reviewing and reforming the way services have been historically organized and structured is also needed at this stage if we want to make sure that mental health is seen, as the slogan says, there is no health without mental health. So as one more part of a human being that needs answer to many things, among them also to mental health.
Thank you for setting the stage there. And I would like to return to the issue of stigma and how to address that through policy solutions more, because it's clearly a huge issue. Professor Wolpert, let me come to you, though, first. I'd like to hear from you about, having heard about these barriers, about the intersection between scientific research and policy making. I want to get this right. You've said your target is by 2032, there should be at least one new pharmacological intervention, one new non-pharmacological intervention, and one new digital intervention available and in use. What can governments do to help get us there?
Thank you. Thank you for having me here. So I think we're at a tipping point in terms of mental health science. So I think we don't often hear the terms mental health and science in one sentence, and we need to start having that as part of our core narrative. It needs to be up there with how we talk about what the opportunities are in terms of mental health coverage. So what governments can do is help invest in that science as part of their investment in mental health. At the moment, the investment is less than 50 cents a head for scientific innovation and development for mental health problems which are holding billions of people back across the world. We need to change that, and I have the privilege of being part of a philanthropy which is investing millions, hundreds of millions in mental health science. I also have the privilege of seeing the exciting stuff that is coming through that is going to change the opportunities for integration in universal healthcare going forward. So we're already seeing new drugs coming. We have the first new drug for schizophrenia in 50 years that is coming through to the market within the next year. We have a new drug for postnatal depression also coming through. We have new non-pharmaceutical interventions that are looking very promising with things around how we change our sleep, how we change our exercise, how we use digital tools to help support us in new and innovative ways. And, for example, innovation around how you can predict when you are going to have a relapse in terms of psychosis just by using your facial expression. So there are some very interesting digital tools arising. And I think that there is a real opportunity for us to galvanize that and change the way we think about what are the interventions we can do and the ways we can change people's lives.
Wow, that's fascinating. Thank you. Nathaniel Counts, you advise the Commissioner of Health for the City of New York on innovative financing policy and research strategies for achieving the city's mental health goals. As I bring you into the conversation, I'm wondering if you can tell us about the economic benefits of investing in mental health services and also how to integrate mental health into the larger health system of a city like New York.
Yeah, I feel like the previous comment set it up well because financing and the need for investment was a really huge theme. And I think sort of traditionally there's been this view that investments in social protection, which I kind of think mental health is part of, and then economic growth and development, there's a trade-off between them. And we have to figure out how do we sort of balance this, a classic efficiency equity argument. But I think what more recent economic findings show is that there isn't a trade-off. And in fact, like mental health, especially from a life course perspective, is like a key factor in driving economic growth and development and a necessary part of it. And so like one study in the US found that for mental health conditions alone, there will be between 2015 and 2050 an estimated $18 trillion in lost GDP because of untreated mental health conditions. And so when you think about like the massive economic toll, and I think we see this, like lots of studies have shown the economic benefits of investing in mental health. I think the big challenge is then going from these estimates of benefit to how do you build that into sort of like national accounting frameworks? How do you make that real for actual budgeting? I think one of the difficulties is like for physical capital, I think we have pretty good systems. So you're going to be able to sort of, spread out the investment over the life of the asset. And that opens up these sort of innovative financing tools. Like if you're building a stadium or a new piece of infrastructure, you can issue bonds based on the expected property tax increases over time. And you have this idea that like we're making an investment and this is going to show up in real budgetary impacts, and that unlocks financing and investment for us. In human capital, we don't really have that as a concept as much. Like all expenses occur that year and there's no benefit in the accounting over time. And so I think some progress being made, I think we're really seeing in like the climate space, there is this movement towards climate budgeting. So New York City and the US as a whole and many other countries are participating in different climate budgeting exercises, which try to build sort of considerations outside of the standard accounting into the budget process. And so, for example, in the Biden budget last year, they showed like here's the actual expected economic losses of an action from not acting on climate change. And then it goes from this sort of like cost-benefit analysis for different investments to like an economic imperative, like we have to do this to avoid trillions of dollars of loss. And so I think to the extent we can think about how to align investments in human development, human capital with the actual accounting and budgeting frameworks, it'll make the investment case real and then unlock innovative financing opportunities that aren't sort of like one-off contracts with like really high transaction costs that face difficulty scaling, and that I think recognize the importance and magnitude of the issue.
Do you have any examples in your own experience in New York in those kinds of innovative contracts that you've struck so far?
So, I mean, in the past, I think there's a lot of different innovations that basically all have different versions of it. So there's been, there's social impact bonds, there's just normal social bonds, which look at certain criteria beyond just sort of standard return on investment for the financing. But they're all sort of variations on the same theme that value accrues over a longer timeline, and we need to sort of capture the different ways that these externalities show up. And so I think there's a lot of different options, and I think the major challenge is streamlining it so that you can mobilize a lot of financing instead of one-off deals.
Right, it's a matter of sort of rethinking how we measure it. Dr. Stella George, I'd love to bring you in. As the Chief Medical Officer for International Health at Cigna, Tell us how a company like Cigna approaches the integration of mental health in its healthcare packages. I know you're a big advocate for preventative mental health and that this is gaining traction as an important aspect of overall well-being. So how is Cigna thinking about promoting preventative mental health?
So in fact, I always joke that when you look at the whole healthcare ecosystem, we have providers, we have pharmaceutical companies, and a lot of other players. The health insurance company is positioned in such a way that we are one of the most important stakeholder to promote health and prevention. If we keep our employer population healthy and have good health outcomes, we grow. So we are we have one of the most important stakeholder. And like my fellow panelist already spoke about how less is invested in mental health. And if you go and take it one step ahead, how much even from that little scant resources, even less is invested in health promotion and preventive activities. And there are numerous studies we have seen in US and Europe where every dollar we spend on health promotion and prevention activities, we have 10 to 14% ROI, 14 times. But why then we don't do it? It's because of the same thing what Nathaniel said, that it has a longer tail. It's not instant. We don't see. And plus there are other bigger problems to solve. So it just gets pushed down at the bottom. And especially from a mental health is a common denominator right now. Issues, everyone, in fact, Aryan was referring to particular statistics about burnout, especially between 18 to 24 years old. When we surveyed them, 98% of them have experienced burnout. So it's like normalized right now. Everyone has something or other. So how do we take this into consideration? And that is where all our solutions is, whether it is services or solutions we build, takes a very integrated approach. We also know that if there are chronic condition and there is an underlying mental health issue, they tend to incur 30% more cost than people who don't have a mental health issue. And then there is also another thing which complicates is the individual burden to the family and the societal burden. We also have our employer group very concerned. Like today, #1 priority for all our employer group is mental health. So everything that we do, it's like mental health screening or building resilience is part of all our clinical programs. In fact, all our frontline staff, including clinicians, they are trained in mental health first aid. So they can screen. In fact, we even use some new innovation we are trying where even though sometimes we meet people and say, how are you? We say, I'm fine. We don't say we are going through something. So there are actually analytics, speech analytics, which can know that, yeah, Stella is saying she's fine, but there's something, but the way her heart rate is going. So there's so much innovation coming to detect that and helping people get the right resource to build resilience. So if your mental state, like your quality of your life is determined by your mental health. So if we can help, in addition to your physical, social, taking care of that mental aspect of mental well-being, I think it goes a long way in terms of even making changes to your behavior, health behaviors, which might have a positive outcome on health. So I would say it's completely integrated. We don't say this is our mental health solution.
Yeah. I was struck by something you said, though, which is that because in large part mental health is maybe a more amorphous or life cycle problem, sometimes it falls to the bottom of the heap in terms of priorities for stakeholders involved. So I wondered if I could bring in Dr. Kestel again and ask about that idea of how can we keep mental health as a top priority for governments and for multinationals, for multilateral organizations?
Well, I would say I'm not sure we could say how to keep it. I would start by bringing.
Okay, maybe that's better. How do you make the case?
Okay, I think that some of the figures and the information that we have are relevant, right, to make the case. The explicit, continuous education information that could serve on one hand to recognize the problem, on the other hand to fight with stigma and to introduce measures that are not only to take care of those who are suffering or are going through mental health issues, but also in the workplace, for example, how to prevent things to happen. And one of the key elements that we have identified to prevent mental health issues to be developed in the workplace is to train managers. So, those are concrete interventions that should happen and should bring. So I think that we last year we produced a report that tried to summarize all what we know right now on mental health, including examples from a lot of countries that could help to bring these as concrete ways forward. Okay, this is your country, these are your resources, this is your capacity, these are your priorities. Let's find a way to bring mental health and maintain it there and keep it there, right? But to bring it as a priority. There are issues that could be done. Everybody can do things from the government point of view to take better care of the mental health of people. So let's bring them up front and make sure that then are systematized and be part of the universal health coverage that we are all talking about.
Yeah, so the answer is to think about prevention.
It's prevention, but it's also care, and it's also promotion, and it's also recovery. There is no way to think that we will prevent every mental health condition to ever come. No, we can prevent some. We can prevent in the workplace. We can prevent with interventions at school with children and adolescents. We can prevent suicide. And with that, a number of other issues happening. But we can't prevent mental health issues to happen completely. Yeah. So that is one important part. The second important part is what are the interventions, the new ones that Miranda just mentioned, the ones that are there, and the different sectors that need to be involved, and the different stakeholders that need to be involved in order to take care of those issues.
Yeah, Professor Wolpert, I wondered if I could return to you on the question of stigma. And what scientific innovation, what role can scientific innovation play in reducing stigma?
So I think what we've learned from cancer, when I was growing up, cancer was called the big C, and people used to whisper about it and they wouldn't say if someone had cancer. Because we now have effective treatments, that is completely gone. Stigma will disappear from mental health when people know there are effective treatments to help it. So although I am a great supporter of anti-stigma campaigns, and I think they are important, the biggest way we will smash stigma is having a way to treat the problem.
Wow. I'd never made that connection before, but it seems key. The stigma will disappear when there's effective treatments. Nathaniel, can you speak to what you've been doing to reduce stigma in New York?
So I was actually, as everyone was talking, I was reflecting on, I think, so what we've been doing in New York, I'll go to in a second, but I think one just sort of general trend that's been really helpful is just the focus on person-centered care and healthcare generally, to the point about, like, when we ask people how they're doing, do they just say fine, or do we sort of prompt more response? And I feel like as there is more of this movement towards person-centered care, you are getting, like, all across the healthcare system more and more sort of elevation of mental health as a core issue. Like, I used to work in mental health advocacy. I remember sitting in a meeting once, and someone asked if anybody had, policymaker had asked if anyone had comments, and someone raised their hand, like, well, what about mental health? You left it out. And I was like, I think I was supposed to say that. So I looked around, who said that? It was one of the cancer organizations. And I was like, oh, okay. So it sort of became very clear that, like, as people begin to listen more to the populations they serve as part of the standard of care, then, like, the sort of, like, base grows because mental health becomes so critical to every aspect of it.
Nathaniel, could you just pause and define person-centered care?
So I think one of the big transitions that undergoing healthcare is this movement towards sort of a model where someone comes in with a complaint and then you use your sort of like specialized medical knowledge to just address that specific complaint based on evidence-based guidelines, versus taking the time to sort of like understand what their goals and values are and then creating treatment plans with them
to achieve them. And I think there's sort of like a general ethos that I think is like sort of infused across all the many different, all sorts of human services as well. And to that point, this idea of like sort of like how do we fight stigma and integration, in a lot of the briefing documents for the high-level meeting, they mentioned this like whole of government approach. And I think in New York City, that is really one thing we get to enjoy quite intensely. So our mental health plan came out some months back, and it was like a whole government approach where every agency had initiatives and programs and strategies involved, from parks to the libraries. And I think like as people take like, you know, have the time and space to listen to the people they're interacting with, like mental health is coming up like everywhere, whether or not that's, people know how to describe it. And it sets an expectation that like, okay, we've raised awareness, like now we need someplace to send people to. And then increasingly you have this like massive coalition of agencies and partners who believe that mental health is core to the primary and overall healthcare delivery system.
It actually reminds me of the conversation that we just had about the combating AIDS and the importance of bringing together different agencies who are maybe even outside of healthcare who can help meet healthcare goals. Claire, I was wondering if there are any questions from the audience you'd like to share.
So Allison at the Department of Homeland Security in Washington, D.C. is wondering if you all have any, concrete ideas about how our organizations can better accommodate mental health differences inside the workplace rather than relying purely on outside benefits programs.
Dr. George, you might want to answer that.
No, absolutely. I think there is so much opportunity because we do have that global infrastructure. In fact, one of the things where we can absolutely take action is in terms of virtual health. And we saw in the pandemic, people just switched to that. And to the earlier question about stigma, in certain geographies, it's still people don't go and tell openly that they are But what we have seen, the shift has happened is the privacy and the confidentiality around accessing mental health support, psychotherapy, or cognitive behavioral therapy virtually from the comfort and confidentiality of your home. So I think virtual health, not only for mental health, even access. I mean, earlier we talked about there is also number of mental health professionals. There is a gap in what is the need and what is actually there. So again, virtual health can play a big role in not only as a modality for people to reach out, but also in triaging, because not everything needs a psychiatrist. But so you can actually see what somebody it might be just loneliness, social isolation that is causing somebody to have mental health symptoms. So all they need might be a coach or somebody, and someone else might need a very specific action. So I think the partnership with organizations like us, we can partner with government and large employer group to provide this infrastructure. In fact, recently, 2 weeks back, we are the partners for United Nations and governmental organization. So when the crisis happened in Morocco and Libya, our crisis support team was immediately deployed in such a short time because people had to go and help. So this was a very valuable resource to triage and have access to care and also mental health, 24/7 support to someone in the language, local language. And it was very well received. And this is not only we offer it for our international plan, we also extend it to the nationals of that country. Even if they don't have insurance, still it's open to the whole national. So these are some examples where we have come and partnered with our employer and the local government to support, reinforce what the lack or just add to the forces so that we can help more and more people.
Devorah, you want to?
Thank you. I wanted to comment a bit on, and it's linked to a number of issues that have been said. We talk about people-centered. We also talk about the human rights of people with mental health conditions. And I think that stigma, according to the Lancet Commission on Stigma and Discrimination from last year, contact with people with mental health conditions, direct contact is one of the main elements to fight stigma. And what I'm trying to say here is that we need to learn to accept that we are different and some people may live with mental health conditions with or without treatment. And they may have a happy life with or without treatment, living with those conditions, if they find a situation that is comfortable to that. And that contributes to stigma, but also is a way of, to fight stigma, sorry, but it's a way of learning to accept that having a mental health condition is not something to be ashamed of or afraid of. There should be treatment, and then there should be the possibility to decide what do you want to do with that. And if we learn to accept that, then it could also be part of, you won't need to hide it in your workspace because of concern of the retaliation or the actions that might be taken because you have, right now, today, very few people are able to say, I have a mental health condition to your employer immediately as something happens.
Thank you for that. Yeah. Miranda.
I just wanted to come in to say there is a great report from the WHO on workplace mental health, which really emphasizes the role of managers in terms of how they respond to people when they arise mental health. Not that managers have to become therapists or have to become mental health experts, but just having a culture in which it can be talked about and supported and thought about actually can make a huge difference. It doesn't require expensive or other inputs.
That sounds like a great resource. Thank you. We've got one question left for everyone. Really quickly, the upcoming UN high-level meeting on universal healthcare is happening tomorrow. I wondered if we could share what we hope will emerge from that gathering. It's an opportunity to make a specific call to the people who'll be attending that. Maybe Nathaniel, start with you.
I think a commitment to mental health with like a developmental life course promotion lens as part of primary health and universal health coverage.
So for me, it would be to treat health insurance as partners, because we have a lot of in support in terms of network or access to care, which we can absolutely supplement to make the universal health care a reality.
Bringing in the partners for sure. Deborah?
There is no health without mental health. There is not universal health coverage without mental health included.
And Miranda?
I think I'm just going to say +1 to all
Plus one. Well, thank you so much for joining us here today, everyone. Thank you.
Thank you. That way or this way? Which way? This way.
Yes, thank you.
And now, please welcome to the stage Dr. Natalia Kanem, Executive Director of the United Nations Population Fund, for a conversation on navigating the nexus, reproductive rights, and the SDGs with FP's Alison Carlson.
And those were a couple great conversations about mental health and AIDS and a number of other conversations that we've had today. Thank you so much for staying with us and joining us today. I'm honored to be able to close out our health forum with Dr. Natalia Kanem. Really excited to talk and focus now about women and reproductive health and sexual rights. There has been some, but maybe not enough discussion yet today about women. And I would love to hear from you. We're amid the SDG global stocktake, and sexual and reproductive health are either directly or indirectly linked to at least 17 of the SDGs and vital for economic and social development. And so when you think about where we're at the moment and amid backsliding on reproductive health and rights in the US and around the world, what are you doing and what is the agency doing to really focus on access to reproductive health care?
Thanks, Alison. Really happy to be here, and I'm glad to see foreign policy focusing on not just health, but the global consensus that this 78th session of the United Nations General Assembly represents, to line up behind the Sustainable Development Goals, which promise prosperity and better well-being for all. And the magic word for all has to include the half of the population, which is women and girls, who are so often much more vulnerable. Now, you understand that we're in an era of questioning the validity, dare I say, even the value of prioritizing women and girls' rights. And this type of backsliding is dangerous. It's certainly dangerous for women and girls who, from a whole host of bodily autonomy issues, I could start with family planning. We could move on to discuss the fact that in 2023, maternal mortality, the preponderance of which is preventable, is stagnating and in some places going backwards when we review this. And of course, the scourge of gender-based violence, which is prevalent in every category of human experience, but women and girls are victimized up until femicide. These are issues that have to do with fundamental human rights and the political will that a health system has to be designed to serve the people who are most in need. So for UNFPA, certainly we are demanding zero unmet need for family planning. This is one of the best investments if you want to look at it dollar for dollar. But in terms of empowering a woman or an adolescent girl, being able to plan when and whether you're going to be pregnant is going to determine a lot of your future. Are you going to finish school? Are you going to be able to hold a job or create jobs as an entrepreneur? Similarly, we say that there's a moral issue to maternal health backsliding. This implies that the woman who is walking to the clinic right now for prenatal care, and it's going to take her a while to get there in the hot sun, needs to be assured that when she arrives, the midwife is going to be there, that the clinic will be open, and the provisions for the supplies that she needs for her good health are going to be there. So again, I think the policies and the prioritization of women and girls has huge benefits for all in society, but inherently in the human rights proposition, we've got to look after the people who need it the most.
Yeah, and you know, your point on so much of it is preventable is really striking. And not only the impact that it has when you address prevention, and when we were talking about resources before and utilization of resources, the impact they can have. And as you're saying, cascading impacts for women's lives, their families, their communities, for countries from an economic and social perspective. It's astounding that there isn't the prioritization that it needs. And so when you think about that, and when you think about this moment, and again, we're all here amid the discussions and high-level meetings about universal access, it's exactly what we're talking about here. But yet it's not being prioritized. And so from your perspective, what needs to happen this week? And how can women and the rights of women and girls be more fundamentally and materially embedded in the discussions that are being had in ways that that can meaningfully translate an impact on the ground?
Well, that's a great question. And in a way, it's saying, why should we be hopeful that things are going to change? We should be hopeful that things are going to change because women are actually demanding these rights. Women are actually not sitting back shyly and watching their bodily autonomy evaporate. There is a demand, even within our meetings at the United Nations this week, and in the civil society, which actually shapes the politics, shapes the policies, and the allocation of resources, because again, if something is worth it, you've got to pay for it. So I have great confidence in the generation of young women who are transforming the discussion, whether online, in person, and in communities. When women's groups and young people's groups are funded, they absolutely understand the connection between data and accountability. You got to count it, you got to measure it in order to prioritize it and in order to know how we're doing. So this is one aspect of UNFPA, which is the United Nations Population Agency, but we transformed to work on sexual and reproductive health and rights because this is how you defend the well-being of the population. And why do we focus on women and girls? Because every data point, every evidence shows who is most vulnerable. So as universal health coverage is being discussed here in the halls of the UN during the General Assembly, there is a clamor from the civil society, but we partner with the World Health Organization. We partner so well with other arms of the UN, especially the humanitarian arms, because women and girls in crisis, I know you discussed climate here today, the mental health discussion that preceded this today. All of these are gendered. All of these affect women and girls, and especially younger women and girls of reproductive age disproportionately. So the plans for humanitarian assistance need to prioritize women and girls issues. Every month, women and girls are going to menstruate. So why not supply for their hygiene needs in advance and with priority? Similarly for family planning, if people know that contraception prevents you from getting pregnant, ergo from needing an abortion, if with access, I mean, it's unconscionable. There's 250 million women waiting for the health system to provide modern contraception that works for them. So I think, we certainly believe that heads of state, but also people on the ground are going to reshape this agenda. And UNFPA certainly will be there to insist that we prioritize the rights of women and girls in health. Can I just also quickly add that it's one thing to say that the service is there, but like I was mentioning, when the woman is walking, if the door is closed, all is lost. Midwives, the backbone of health services for women right now in Afghanistan, in many parts of Africa, in all the 150 locations around the world where UNFPA works, midwives are a scarce, precious nursing resource. And we've joined with others to say we're going to help train more and double the availability of midwives on the ground in the communities where it counts.
You raised so many important points about assessing what the specific issues are in countries and communities and having the data to be able to really understand that in a way that we can inform the policies that are being developed, the interventions that are contextually relevant and driven by the local communities. And so I appreciate that, and I think so much more needs to be done to that end, and also the partnerships that you're talking with those on the ground. And so, in the few minutes we have left, what then are your hopes for this week, and what needs to be done to galvanize not just more women and girls, but an understanding that this is a collective action problem, and we need to incorporate everyone? What else needs to happen?
Great points, Allison. Two things need to happen. One is deliberate financing for the type of development which gives the greatest good for the investment. And here, like this week, it's been so exciting. Yesterday, Melinda Gates announced $100 million towards sexual and reproductive health and rights. She was joined by the Children's Investment Fund Foundation, CIF, who put up another, between the Global Financing Facility and UNFPA, another $100 million. We want domestic financing. We want women and girls, family planning, everything that we've been talking about built into the regular budget of every country. And we also, and this is the second part, we want to depoliticize this debate. We want women's rights to be respected without the need for consent of your husband or whoever it is that has to sign for you. As an intelligent human being who knows what's good for you and the family, we want women's agency to be fully respected. And here, the guys are going to have to step up. Men hold power in the patriarchal societies that we have at the moment. And it's a wonderful thing for a young sports guy to interrupt misogyny online and say, no, 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 this is wrong and stop it. But it's also important for policy, which is primarily set by men, to be designed with the women and girls who are affected at that table, for the young people to be invited in. So I think that's going to make a big difference, and that's what universal health coverage is going to put the universal in UHC.
Very well put. Thank you so much for joining us and for your work. Absolute pleasure. Thank you.
Thank you. Thank you.
I don't think we could have ended on a more constructive note than that one. So thank you all for staying with us. There have been so many threads throughout the conversation today that have been distinct and focused, but also very much aligned, and some common commonalities between the topics and the themes. We know we need to crowd in capital. We know that we need to align activities and expertise. There is so much effort that is happening and being mobilized from governments, from practitioners, from industry, but often siloed. We were hearing that repeatedly today. How can we more effectively harmonize that and align those efforts so that those resources and effort aren't lost? You know, I think we often talk about partnerships, and it's not a trite throwaway. It's meaningful, and I think that is one of the things that we can really focus on here is what does that mean, and how can those partnerships really be strengthened and deepened in meaningful ways to take advantage of that complementarity. You know, I think that's how we're going to drive action and impact. So thank you all. I've had the opportunity to meet several of you in the room, and thank you for joining online. We really appreciate you being here and the work that you're doing. So please join us for our afternoon programming as well. I wish you all the best as you go forward in your work, and thanks again.